I'm Tom Draper, President of the American Association of Cardiovascular and Pulmonary Rehabilitation. Your affiliate organization is a great way to stay connected with professionals across our field. But I'd like to share with you what we're doing on a national level to support cardiac and pulmonary rehab. Healthcare reform is a constant evolution, and changes are occurring rapidly and often. The most drastic reforms have been the shifts from fee-for-service payment models to value-based payment models, and now payment models designed at reimbursing for episodes across the care continuum. These changes can be confusing and difficult to understand. AACVPR is positioned to help you navigate it all. Economic and social factors are driving this need for healthcare reform and this push towards episodic payment models. The aging population is increasing the demand for acute and post-acute care services. The traditional fee-for-service payment models are not sustainable with this aging population and their demand for healthcare services. Growth in post-acute care spending makes controlling these post-acute care costs a focus for Medicare. Additionally, appropriate care, and in particular, hospital readmission rates, are being targeted as an area to promote efficiency and quality in healthcare. Payment episodes of care are seen as a solution to combating these healthcare trends. The care for a cardiovascular patient can be complex, expensive, and at times uncoordinated. The coordination of care from acute care episodes to long-term recovery and risk factor reduction must be done without the presence of silos. The acute hospital team must coordinate with the outpatient providers, who must coordinate with the cardiac rehab teams. Not only is this effective and efficient for the patient, new payment models are demanding this level of coordination. CMS will institute bundle payments for AMI and CABG that will cover the period from hospital admission through and including 90 days after discharge. The bundle payments will be fee-for-service Medicare patients, which excludes Medicare Advantage patients, with these diagnoses, and will be implemented in 98 metropolitan service areas, or MSAs, across the country. This bundle payment approach is being expanded to include these two diagnoses after a successful bundle payment program launched for joint replacement last year. Together with this change in reimbursement is an exciting incentive program to increase referral to and participation in cardiac rehab programs for patients with these same diagnoses. The incentive includes a $25 bonus. This is in addition to the regular fee-for-service payment that cardiac rehab programs get for sessions 1 through 11. And then the incentive bonus increases to an additional $175 per session for sessions 12 through 36 within that 90-day post-discharge period. What is very important, the incentive payment goes to the hospital that discharged the patient. So it is incredibly important that you have or build strong relationships with your referring hospitals. There are 90 MSAs included in this incentive program, 45 of which will come from the bundle payment MSAs, and 45 from all eligible MSAs not chosen to participate in the bundle payment model. Your program may be in an MSA that is part of the bundle payments, the incentives, both, or neither. AACVPR can help you determine which group your program falls into if you don't already know. There are two primary goals of the cardiac rehab incentive payment model. Number one is to understand whether and how the effects of the financial incentive for use of cardiac rehab services differ depending on whether a beneficiary's care is covered under bundle payment or fee-for-service. Secondly, to examine each intervention's separate effects on quality and efficiency of care the beneficiaries receive. CMS will examine if cardiac rehab affects the AMI or CABG outcomes important to them, such as hospital readmission rates, HCAHPS patient satisfaction scores, mortality, amount of care deferred beyond the 90-day post-hospital discharge episode, and most importantly, cost savings. So what is evident in all of this? That cardiac rehab is the best solution for high quality, efficient cardiovascular care across the continuum. The bundle payment models have several benefits to your programs and to your hospital systems, including increased referrals to your programs, increased awareness of your cardiac rehab programs, a financial benefit with a two-tiered incentive payment, which is in addition to the customary reimbursement for cardiac rehab services, and increased opportunities for you to redesign and create innovative and novel practice models. So depending on which group your program falls into and what role you play within your organization, you have to take some concrete steps today in order to prepare for this new reality. If you're part of the bundles, the incentives, or both, there is no time to waste. These bundle payment models certainly have benefits to our rehab programs and our hospital systems, but we should not ignore the benefits to our cardiac patients, such as increased access to our programs, earlier engagement in our cardiac rehab programs, and more immediate support post-hospital discharge, which should lead to a decrease in rehospitalizations, incentive payments, which can be used to directly benefit the patient, such as transportation, coordinated and more satisfactory care, and improved outcomes with better care through lower costs. So what is your role as a program leader in this new value-based world? First, you have to understand and know your rehab program, the clinical benefits, the business side of it, and the importance that your staff plays into this. You have to understand how to leverage your cardiac rehab teams. Know what resources are available for you and for your team through AACVPR. You have to articulate how to integrate cardiac rehab into quality and continuum of care discussions. And finally, get an audience with those decision makers, administrators, and providers. First, you must articulate the patient benefits of your program, such as improved functional capacity, increased knowledge of heart disease, improved adherence to positive lifestyle changes, enhanced compliance with medical regimen, increased self-esteem and confidence, reduced subsequent morbidities and mortalities, and improvement in cardiac psychosocial risk factors. And it is very important to understand and share the scientific evidence-based data from cardiac rehab, such as decreased all-cause mortality, reduced risk of cardiovascular mortality, decreased severity of angina and need for anti-angina medications, decreased rehospitalizations, decreased cost of physician office visits and hospitalizations, fewer ER visits, and decreased cardiac event rates. Secondly, it is important to understand the business side of your rehab program and the financial health of your cardiac rehab department. But you should not ignore, and you should be able to articulate the additional financial benefits to your system, such as improvements in quality, decreasing overall cost, readmission penalty avoidance, downstream revenue, and additional revenue streams that your program might bring in. As we embark on these bundle payment models and this value-based care environment, it is critical to have a strong relationship with your administration. When you go to your administration, you do not want to start with asking for all the resources necessary that you think your program is going to need in order to deal with the increase in referrals or adherence to your programs. You want to start with sharing your aspirational vision of your program. Articulate clearly your role as a solution to bundle payments. Share your program's performance and the expertise of your staff. Describe the alignment that your program has with the service line strategic priorities. To gain the support from your administrators of your cardiac rehab programs, you must first understand the implications. Make sure you educate yourself about them. Make sure you understand and can articulate that it's a fixed amount of payment to that hospital to treat AMI or CABG patients from admission through and including 90 days after discharge. Teach your administrators about your program's role in this bundle payment system. Talk to them about the efficient and timely referrals from inpatient to outpatient cardiac rehab. Talk to them about the need to engage patients quickly in an outpatient rehab program, how you need to prepare for the increased volumes of patients in our outpatient programs, how our programs help keep patients in the program as long as possible to fully realize this incentive payment. And finally, the need to possibly reinvent your program's design and practices to accommodate increased volumes and to tailor appropriate individualized interventions. So what are the benefits if you get your administrators' buy-in? If you get their buy-in, it will provide them with a clear understanding that investing in your program will lead to long-term benefits, that the hospital or system will be willing to seek opportunities for your program to grow and expand. They may allocate marketing and outreach resources. They will internally promote and highlight your program as the solution to value-based care. They will be willing to invest capital resources in your program. What is key, what is critical, is to get with them early, get their buy-in early, which leads to long-term success. Finally, how can your program achieve success? You must be open to change, refer to and share best practice examples, potentially redesign programs to accommodate more patients. If you're an AACVPR or joint affiliate member, utilize AACVPR webinars. Be on the lookout for other educational opportunities in your area through AACVPR or your affiliate. And finally, stay informed through AACVPR's website and reimbursement updates. It is important that you create forums to have dialogues with administration and referring physicians. You again want to talk to them about improving timeliness and volume of referrals. Will help patients get into your program sooner and achieve the clinical benefits that we know rehab programs can offer. Review your policies and procedures, as they may be barriers to change. And finally, consider innovations in the design of your program and the delivery model of care. Some final key discussion points. These models are putting a spotlight on cardiac rehab. That is a good thing. Take this opportunity to highlight your cardiac rehab program within your institution. Identify and know the key stakeholders, administrators, physicians. Prepare for more referrals. Understand the potential financial incentives and how they impact your referring hospitals. Prepare for more patients. Be able to innovate and be more efficient in the delivery of care for your programs. Utilize the AACVPR Roadmap to Reform resources to help you. Share best practice examples among your programs and within your affiliates. Even if you are not a chosen MSA, you must begin to prepare now for value-based care. AACVPR asks that you embrace these upcoming changes. Engage, manage, be bold, be resourceful, be accountable, communicate with AACVPR, and finally, energize and volunteer to help. Check out aacvpr.org for more information, including more than a dozen turnkey strategies to prepare your program. Also, there's a full list of the MSAs and their bundle or incentive status, and much, much more. For AACVPR members or joint affiliate members, we have several webcast recordings with more detailed information about these changes, background to share with your programs, even a whole webcast dedicated to hospital administrators. I personally want to thank you for your commitment to your affiliate, to AACVPR, and most importantly, to your patients.